I want to talk about sports medicine this morning and what's new. So just to give us a little thing. So a couple of things to look at this morning that I think are useful for you in your practice as you look out at kind of general musculoskeletal complaints. Maybe you're like me. I can't go to a neighborhood party. I can't go to a family reunion without somebody dragging some x-rays out of their purse or on their phone. And what do you call a doctor who looks at x-rays like this or looks at x-rays on their iPhone? Do you know what we would call that doctor? Defendant, right? That's what we call that doctor. So if you see people come in with some of this stuff, maybe this can be useful to you, some of the new things that we're doing. So first would be hydrodilatation for frozen shoulder. Frozen shoulder is a bothersome thing. It's out there, and there really is a new treatment that I'm super excited about. We've published just barely our first review of what this looks like, and just starting a larger case series in conjunction with a physical therapist, I think is going to work out to be a really nice treatment. Talk about the posterior osseous nerve. No deduction in points if you don't know what that is. That's a little tough one, but you do know what lateral elbow pain, lateral condylitis is, and that's a mimicker of this. And then we'll just talk about platelet-rich plasma, some of the things that we're learning and best practices for people who are looking for regenerative medicine therapy. So moving right along. Okay, so frozen shoulder. Here's the difficult thing about frozen shoulder. I guess I'm going to choose the right over here. So if you look at frozen shoulder, this is what happens. You get pain that happens first, and then stiffness that happens later. This Alice the camel has two humps graph, all right, and then it gets better over time. The problem is that time course can be pretty long, and so we've tried a lot of things to think, what's going to make a difference for these people? What can we do to shorten this course, reverse this process of frozen shoulder that's idiopathic and bothersome for people? So we tried physical therapy. If you do physical therapy on this, it doesn't work, right? So you can do all the physical therapy you want on this upslope right here. Mother Nature is going to win. It's going to keep getting stiff. It's going to keep getting painful. And you're going to end up with a frustrated physical therapist and a frustrated patient because they'll use all their physical therapy benefit here, and it's not going to change really anything. Physical therapy is helpful on the downslope down here when the shoulder is thawing on its own. Then physical therapy can help you get more motion back that you need, and it can also help things progress faster, but it's not going to help very much on this upslope, so it's a difficult thing. We've tried manual therapy. What happens if we just yank people around? Well, what happens is they hurt a lot. So we put them to sleep, right, or we give them nerve blocks, and then we yank them around a lot. That doesn't work very well either. We've thought about operative lysis of adhesions. We'll put them to sleep and then cut out all those little fibrous bands and see what we can do about cut the capsule up a little bit. That doesn't work very well either. We've injected steroid, and I will say that any sort of steroid injection will help people with adhesive capsulitis with their pain, okay? It's not going to help the stiffness, it's not going to help these curves here, but it will help their pain go down, right? So that's useful. I think the best pain relief happens with an intra-articular, inside the glenohumeral joint steroid injection, but any sort of steroid injection will help some. So that's helpful for pain, not for stiffness. And then, we live in Utah, so we have to talk about, is there organic bear snot we could rub on this, or is there something that we could do that would be different? And I haven't found anything that works on that either in all the samples that certain companies that will go nameless send me. So that's not really working. So, and the really bad thing is that this comes under, they always say that half of what you learn in medical school is false, right? I learned in medical school that frozen shoulder symptoms lasted for 9 to 12 months. That has not been my clinical practice, right? I have people who suffer with this. Usually, if they're over 50, it's going to be an 18-month. If they're over 60, it's 24 months before they really feel like they have their shoulder back and are doing what they want to do. If we just let them run out and go. And nobody's very happy about that, right? Nobody's very happy to hear, oh, your right shoulder is not going to feel great for 24 months. Nobody wants that. So what can we do? So here's a new thing that we could do. Hydrodilatation actually combines a couple of procedures that have shown some partial efficacy previously. It is an office-based procedure. You're actually looking at what that looks like right here, okay? It's an ultrasound-guided shoulder procedure, patient in your office. You start out with a suprascapular nerve block. This is very small, but what we're looking at here is actually the suprascapular notch right here. The suprascapular nerve is right in here. The spinal glenoid notch right in here, excuse me, not the suprascapular, spinal glenoid notch, suprascapular nerve. And this is full of fluid from us having given that a block. That block in itself does two things. First of all, that has some efficacy for frozen shoulders, some partial efficacy just as a treatment. The second thing is the next thing we do to them is going to hurt quite a bit, so it helps decrease a little bit of the pain. The next thing we do is a high-volume ultrasound-guided glenohumeral injection. So we're actually injecting 51 cc's of fluid into the glenohumeral joint capsule and stretching that out. We're actually trying to rupture it. It takes two people, so you can see, oops, sorry, we're going forward there, we'll go back. So you can see this is a big long needle here connected to tubing on this big 50 cc syringe over here that my assistant's getting ready to push in there. All right, so we can do that. This looks like this. We'll just kind of preview here. This is the glenohumeral joint. This is the humeral head here, glenoid over here. Here's the space where the needle's coming in. And then if we look at what this looks like, so play this video. Great, here we go. You can see here that the fluid's going to come in here. You'll start to see this big space open up, right, as that capsule expands and we get that like that. And then that capsule's going to rupture and that space will actually get smaller. Boop, see it rupture right there. Now the space starts to shrink down again. And that's a successful hydrodilatation of the frozen shoulder. So after we've done that big stretch with, we use mostly normal saline, a little bit of ropivacaine, a little lidocaine, and a little steroid in that for the pain relief we want. Then the next thing we do is immediately we take those people through a manual range of motion. Right after we pull the needle out, we range that shoulder around in the 7 cardinal planes of motion. It's amazing to me that just doing that procedure, that hydrodilatation, they can move 10 to 20 degrees more in motion just instantly right after that. Then we send them, this is what takes a little scheduling coordination, we send them immediately from the office to physical therapy that same day. They just walk across the hall in my office and go right to physical therapy. Physical therapy does a little bit more cranking on them, but most of what they do is teach them how to perform these home exercises with a shoulder pulley system. And we send them out to do daily home shoulder exercises after that. And that seems to do the trick. So this is what we see, is we see that I have these people come back and see me at 1 month and 2 months following this. At 1 month, they report a 90% pain decrease, okay, and a 50% decrease in their stiffness, or half their motion is back. And then by 2 months, so they're there on the graph now, and by 2 months, they have a 98% pain decrease and 90% of their stiffness is gone. And so what we've done is we've taken these curves here, instead of progressing them out to 18 to 24 months, we get them here 1 month, here 2 months, and we don't have to put up with any more of this 18 to 24 month thing. So this has been a really slick thing for us. Again, we continue to study this. We're publishing a large 50-person case series on this. Hard to do a randomized controlled trial on this because nobody wants to be in the control group right now. But we're doing a big 50-person case series with our physical therapy folks to look at what these look like. But very promising results for this hydrodilatation for frozen shoulder. Okay, so that's hydrodilatation. Let's talk about posterior osseous nerve entrapment. Again, if you're looking at the lateral elbow, it's tough. So I was always taught that lateral epicondylitis is tennis elbow, right? Medial epicondylitis is golfer's elbow. If you've been in sports medicine for a while, you recognize that good tennis players don't get lateral epicondylitis, they get medial epicondylitis, and good golfers don't get medial epicondylitis, they get lateral epicondylitis. So we solved that problem. We just call it country club elbow, and we don't really care what goes on, right? So how do we get a more nuanced approach to lateral elbow pain? This is common as dirt on a playground, right? Lateral elbow pain is out there in vast droves. And my unnuanced approach is, well, just treat it like it's lateral epicondylitis because 95% of it is. And that's true, all right? So you can just guess lateral epicondylitis. But if we don't want to guess, there are a couple things we can do just on palpation to maybe help us a little bit. The first is to recognize that if this is going to be lateral epicondylitis, it has to hurt on the lateral epicondyle, okay? Like right on that bony prominence, or no more than 1 finger breadth. I have kind of fat thumbs, but more than 1 finger breadth anterior to that, or distal to that, down the tendon. So it's got to be right there on the epicondyle. If they have pain inside kind of this green triangle, okay, kind of in that, just inferior to that, probably what we're dealing with is an intra-articular process, either some osteoarthritis, loose body, maybe an infection. And then if they complain of pain elsewhere, down in kind of the meat of the muscle, that's something called posterior interosseous nerve entrapment. Okay, so the posterior interosseous nerve tends to give things. It's a big mimicker. A lot of people feel the same things, same type things, but their tenderness is often more in the muscle belly. So that's the world's simplistic view. I'll tell you again, that's one of those kind of lies of medical school that this works out super well. Most of the time, people with lateral epicondylitis have pain that's vague and kind of press around. You're like, well, they hurt everywhere, so it's hard to know if they really hurt on the condyle. It can be a little tough. So the newest thing that I think is just, it's revolutionized my practice of lateral elbow pain is that for people who are hard to figure out, ultrasound is fantastic, right? You can throw the ultrasound probe on here, you can see the lateral epicondyle, you can see the common extensor tendon, you can see the joint, so you can see if that's swollen, if that's going to be more of an arthritis type thing or a joint effusion. You can see the radial head. This dark thing over here is the annular ligament. That can hurt sometimes. You can see all that, right? If you use a little bit of fancy Doppler flow, you can actually look at that tendon, you can grade it out, and you can say, is this a normal tendon, right? Is this an inflammatory tendon that's super hot and acute, right? Is this a degenerative tendon that's not hot and acute, but this is like month 6 or 7 of pain, it's starting to get some tears, but the ligament's still intact. I look at that and I just think, ooh, that needs my platelet-rich plasma. Really good studies on that type of lateral epicondylitis or that type of degenerative tendon tear for platelet-rich plasma. We'll talk about that. Or if it's a mixed picture, right? Do they need more therapy and work on that? But it's just really nice to be able to look and to not guess, right? And be able to press on things and just say, you know, is this your lateral epicondylitis that's here? Is it the joint that hurts here? Is it that? But you can actually see where you're pressing and see where they're the most tender, and that's really revolutionized my practice. So instead of just this, right, I'm left with something better. I want to talk more specifically about posterior osseous nerve. Yes, you can see that on ultrasound too, right? There it is, right? There it is, and it's actually right over the radius, and so you can easily find this on ultrasound and press on that and compress it against the radius, and if that's their major pain, they say, yes, that's my pain that I feel, that's golden, that's wonderful to know that, because the treatment for posterior osseous nerve entrapment is very different than for lateral epicondylitis or a tendon problem. This just happened to me yesterday in clinic, yesterday afternoon. Had a patient come in. She's kind of like that lady from the Bible who had spent all her living these past 9 months on trying to get treatment for her severe lateral epicondyle pain. She's a medical coding instructor, and I don't know about the rest of you, but I told her, please, can you stop being a teacher and come work for us in Intermountain, because we need more people who actually do good medical coding. Anyway, but she couldn't work because their lateral elbow pain was just so severe, right? Just very difficult. And as we did the ultrasound and stuff, she was tender over this posterior osseous nerve, and that's what was really bothering her. So what do we do for her, and what do we do for our patients who have this condition? If you can see it on ultrasound, then you can inject it, and that's what we'll do, is we do kind of a diagnostic therapeutic block. So you can see needle would come in this way, right? And then we look for this circumferential halo. We want to use about 3 to 4 cc's of lidocaine and a cc of your steroid of choice. I like triamcinolone. Look for that circumferential halo around the nerve and just block that nerve. And then we call the patient in 2 to 3 days to see what their effect is. We didn't have to wait for the lady yesterday, right? We put that in there. I went to see another patient and came back and just sort of checked on her, and she said, oh my gosh, my pain is gone. For the first time in 9 months, I have no pain in my elbow. This is wonderful, right? So that's a very good sign, and we'll see what it does. If the pain relief is more than 75%, okay, we think they've done pretty well. Then if they've got a little bit, because it can coexist, if they have a little bit of lateral epicondylitis that's there too, or a little bit of tendon issues, then you can start your home exercise program and just wait. A lot of times with these steroid blocks, the pain doesn't come back, right? It's curative, it's diagnostic and curative, and you're done. If it does come back, you can use a D5 water hydrodissection technique to just put D5 water around this. You don't want to repeatedly put steroid in there, but the D5 water works fantastic, kind of mechanically separates out some of the fibrous attachments that are compressing that nerve, and people feel a ton better with that. So the one thing you got to tell people, right, and the one thing this lady told me when I came back to see her about half an hour later is, don't forget to tell her about the wrist drop, right? This is a motor nerve. It doesn't really have much sensory component. It's not going to get a lot of numbness from this, but it innervates the extensors of the wrist, and so they walk around like this for a couple hours till that lidocaine wears off, right? So Tell them about that, or they'll call you. They'll be fine the next day, and they'll still have the pain relief from the block. So that's why I want to call them in a couple of days to see how they're doing. But that's been a great trick for me as far as getting better results for this bothersome lateral elbow pain. People do better. I mean, you can just treat it with exercises and see how it goes. But for people who are not getting better, an ultrasound look, an ultrasound-guided diagnosis, and some of this nerve work can really be helpful. Let's talk in the 3 minutes. I wanted to give some time for questions, so 3 minutes here on platelet-rich plasma best practices. Yeah, platelet-rich plasma in sports medicine, right? It's controversial. Here, platelet-rich plasma, regenerative medicine for so many things. Smaller house pavements, bigger anatomy, whatever. Does it work? Does it not? I don't know. But for sports medicine, I can tell you some things that works for, and we'll get with that. It's a cash-pay service largely, which is just problematic. There's a lot of concerns about that, a lot of issues. It's important to understand that TRICARE and WellPay are two insurers that do cover platelet-rich plasma for limited indications, and that's worked out well for us to have patients with that. And then for some things that, what does the evidence really say? What inside sports medicine, what could PRP be reasonable for? So there are some things I think there's good evidence for. So mild to moderate knee OA, there's good evidence for this, okay? It's better in patients who are under the age of 50 to 60, maybe feel like they're just a little bit too young still for knee replacement surgery. Their knee OA is not horrible, but it's keeping them from being as active as they would like to be. The poster child for this is probably standing in front of you, right? ACL tear 30 plus years ago, 8 knee surgeries. My knees are a mess, right? I still have young kids at home. They want me to run the Freedom Run 5K with them and play sports with them, and my knees don't love to do that. So for many years, I formed a military, so it was free for me. That's kind of how I got into the platelet-rich plasma environment. It's been great for me, right? And I have patients who this allows them to get into that. You can't run marathons if you have knee OA like mine, no matter how much PRP you dump in there. Even on continuous infusion, I don't think you can run a marathon with that, right? But you can run a 5K or a 10K, and you can be active, and you can do that. I think that's a good indication. We've got pretty good evidence for that. Lateral condylitis, like we talked about. If you have somebody who has that degenerative tendon, right? Degenerative tendon, but that the lateral collateral ligament is intact underneath it. They've got pain for a while, not responding to an exercise program by itself. Boy, this is slick. Good protocol for this. People get better with this reliably and do super well. Gluteus medius, gluteus minimus tears, trochanteric pain. Again, this bothersome long-term. We can see those tears on ultrasound. Nobody wants to operate on those. Those are really difficult operations, and people do very, very well with PRP and a good rehab program. And then chronic muscle tear or myotendinous junction tear in athletes. This helps it heal faster, stronger, so it doesn't continue to re-tear. I guess what I'd say for all these evidence things is that probably a third of the magic is in the PRP injection, right? A third of the magic is in kind of the talk with the athlete about what's going to happen in there. And then a third or maybe half of the magic, I'm bad at math, is the rehabilitation program that accompanies the PRP injection to make sure we stage that and build that tissue up and take advantage of all the things that the PRP can do in there to help signal the body to heal. So there's good evidence for those things. There's less evidence, I would say bad evidence for these things. So plantar fasciitis, not sure that PRP is the best treatment for that. I think shockwave therapy is what we should be looking at for recalcitrant plantar fasciitis as a first line. Patellar and quad, sorry, I should say quad, not quad tendinopathy. Patellar and quad tendinopathy, again, I'm not sure PRP is first line for that. It might be okay, but I really think the 10X procedure, something we talk about later, is probably the first line for that, for recalcitrant stuff of that. Hip and shoulder OA does not seem to respond the same to PRP as knee OA, and so I'm not sure that it's a great choice for PRP. Rotator cuff tendinopathy is mixed. Some people it works well on, some people it doesn't work well on. Kind of tough to know. You got to choose your patients wisely. They got to know that the evidence there is not great, so not as good as the other side. What to look for? So if you have somebody who's looking for PRP or have somebody who's looking for regenerative medicine, what would I tell you as my guy that doesn't get paid any extra no matter how many of these I do? Number one, don't ever let anyone give you PRP like this, right? PRP is very expensive. It's highly inflammatory. It's got to go in exactly the right place. There is no way on this green earth that this guy knows where this needle is going, right? He just doesn't know, right? If you're going to spend hundreds of dollars on an injection, for heaven's sake, make sure that the physician knows exactly where the needle's going. So insist on ultrasound guidance, right? This is a precision technology. If you're going to spend hundreds of dollars, you want precision-guided bombs. That's what the Air Force is big on, right? So we want a precision-guided missile. Make sure you get an ultrasound guidance there. You're looking for a concentration of platelets that's 6 to 10 times your serum concentration. So if you go in and the doctor says, I'm going to give you 3 cc's of platelet-rich plasma, you're looking for a blood draw that's about 30 cc's of blood because you want that 10 times concentration of platelets. If you go in and someone's going to give you 10 cc's of PRP and they do a 20 cc blood draw, that's not going to cut it for you, right? That's going to be that organic bear snot we talked about before, and that might not work out great for you. You want to make sure that the doctor's talking to you about leukocyte-rich versus leukocyte-poor. There is evidence that one is better than some things for the other, and you want to make sure you have that conversation. So if that's not on the table, then you're probably not at the right spot. You're looking for somebody with experience doing this. You don't want somebody who just does this occasionally. You want somebody who knows what they're doing and knows what they're doing in that body part. For example, I do a lot of these injections, did a ton of them in the military on our special operators, found them very helpful. But if you have a spine problem, I'm not your guy, right? I don't have experience with that. So I can't do, I can help you with your back pain, but I can't do PRP in that region. So make sure you're dealing with somebody who does that body region where you are. And then just look at the cost. These things are, the cost on these vary widely and crazily, right? So just as a reference point for us in Intermountain, across the whole medical group, it's a standardized thing. We have the same machine, the same great machine, and the cost is the same. It's $450 for a single site, $650 if we do 2 sites on you in the same day, right? So if you're being charged over $800, you're basically buying that guy a boat. So don't do that, right? So you can get it cheaper than that. So be conscious of that. There are reasons why people might charge up to $800. They may not be able to have the volume discount, but you can get a really good PRP injection with a really good kit and machine for less than $800 for an injection. So those are some best practices to look at. That's what we've talked about. You all have been super nice. We're going to try to get these guys back on time. If there's any questions for me, I'll hang around in the back a little bit. But thanks for putting up with sports medicine this morning, and hope you have a great rest of your day. I will. So again, big forehead, gray hair, been around a long time, and prolotherapy, we used a lot of prolotherapy in the military before we had access to PRP. Before TRICARE started to cover PRP, we did use prolotherapy. Prolotherapy is probably better now described as a hyperosmolar dextrose injection. You can use dextrose. Dextrose has some really interesting properties. At about a 5% concentration, it's really good for nerves. It's like their favorite food source. It helps reset nerves. So you hear about D5 water hydrodissections, or sometimes you'll hear about a lift-off procedure. That's not prolotherapy in the term you're thinking of, but we do use that a lot for recalcitrant nerve pain or entrapped nerves. That's what I would use in that posterior osseous nerve that responded to steroid injection, but then the symptoms came back. The prolotherapy you're probably thinking of is like a 25% dextrose solution, often used as kind of the poor man's PRP. It works for many of the same indications and can be helpful for many of the same indications. You have to do that injection. If PRP is a sledgehammer, prolotherapy is just a regular hammer. So you're going to have to hit it more times, right? So it's 3 to 5 injections instead of 1 injection. Patient selection is very important because, number one, they have to have the right thing, and number two, you have to like them because you have to see them 3 to 5 times, do these injections on them that are painful. Rehab is important, so finding someone who knows what they're doing on that is important. There are some indications where I think prolotherapy is better than PRP. Okay, so chronic osteitis pubis pain, I think that's fantastic, right, for that. Rib pain, very helpful. I think Prolo is better for that. And SC joint pain, I think Prolo has better efficacy than PRP. So there is a role for prolotherapy, hyperosmolar dextrose. finding people who know what to do with that is a little bit of a trick. So send me an email. We'll certainly get you to people who can do that. Again, it depends on how people bill that. That can be cash pay. Sometimes we can get insurances to pay for that because it's not that expensive. So great question.